My name is Dr. Brandon Harden. I'm a pediatric cardiologist with Children's Healthcare of Atlanta Cardiology. I have a special interest in pediatric dysautonomia, and I am one of a few physicians who help manage our complex long-term syncope and dysautonomia patients through our specialty clinic that we call Syncope Clinic. I look forward to talking with you today about pediatric dysautonomia. Today, we were going to be covering a lot of information regarding dysautonomia. The objectives are found here for your information. We are going to review the common types of dysautonomia, including the variety of terms that are often used. We are going to discuss the signs and symptoms reported in patients with dysautonomia. Next, we will review the common presentations and etiologies of dysautonomia. And lastly, we will discuss both non-pharmacological and pharmacological therapies often used in pediatric dysautonomia. First, let's talk about the basics of the autonomic nervous system. The autonomic nervous system controls the automatic functions of the body that we do not consciously think about, such as heart rate, blood pressure, digestion, dilation and constriction of the pupils, kidney function, and temperature control, as well as many other functions throughout the body. The sympathetic nervous system is commonly associated with the fight or flight response, those bodily reactions that you need to respond quickly in an emergency. When faced with a life-threatening situation, your human instinct takes over, and you either fight the danger you are facing, or you take flight and run away from the danger. Your sympathetic nervous system allows your body to do this rapidly. For example, in the face of danger, your sympathetic nervous system will cause bronchial dilation. This allows you to breathe better while you are fighting or running away from the dangerous situation. Likewise, your heart will beat stronger and faster, also prepping the body to take flight or take fight. The parasympathetic system, on the other hand, is commonly associated with rest and digest responses, those bodily actions needed to restore energy and rest the body. For example, chewing food triggers the parasympathetic nervous system to increase production of saliva and to increase digestion in the gut. So what exactly is dysautonomia? As mentioned before, the autonomic nervous system controls those automatic functions of the body that we do not consciously think about. Autonomic dysfunction is an umbrella term used to describe malfunction of the autonomic nervous system. This is not a rare disorder or diagnosis. Over 70 million people worldwide live with various forms of dysautonomia. There is no cure for this commonly encountered diagnosis. Despite the high prevalence of dysautonomia, most patients take years to get diagnosed due to lack of awareness amongst the public and within the medical profession. There are multiple types of dysautonomia. I've decided to separate things out between simple and complex dysautonomia. We'll talk about each of these in further detail as we go throughout the talk. Most of the talk, however, will be focused on the more complex forms of dysautonomia, those complex patients that require a higher level of care. To start with, we have simple dysautonomia. These include neurocardiogenic syncope and reflex syncope. Complex types of dysautonomia include orthostatic intolerance, postural orthostatic tachycardia syndrome, or POTS, and dysautonomia secondary to other medical conditions, such as diabetes, multiple sclerosis, rheumatoid arthritis, celiac disease, lupus, etc. Simple dysautonomia. Let's start with neurocardiogenic syncope. This is the classic or typical fainting that occurs with the upright position, but is not triggered. Basically, this is fainting that occurs when someone stands up quickly or briefly, and they have an inefficient or inadequate autonomic nervous response. This is the most common form of dysautonomia. Typically, these patients have minimal to no additional systemic symptoms. With the upright position, the patient experiences peripheral vasodilation with subsequent decrease in blood pressure with a slow or lowered heart rate response. So fainting often occurs because of low blood pressure and inadequate heart rate response to the upright position. Reflex syncope includes the following diagnoses: vasovagal syncope, carotid sinus syncope, and situational syncope. Vasovagal syncope is classic fainting that is triggered. This can be triggered by emotional stress, fear or an anxiety, pain. Classically, we've experienced patients who faint with the sight of blood or needles, and also those with prolonged standing, such as a groomsman at a wedding. Carotid sinus syncope occurs because of constriction of the carotid artery in the neck and can occur after abruptly turning the head, often while shaving, or while wearing a tight collar. In pediatric patients, we often will have patients present with what I would call stretch syncope. These are patients who stand up, put their arms above their head to stretch, which results in carotid artery compression, as well as orthostatic changes, including orthostatic hypotension. The combination of orthostatic hypotension and compression of the carotid artery from stretching results in dizziness and fainting. Lastly, we have situational syncope. This occurs after certain biological processes or activities. Some classic examples include fainting or dizziness immediately after urination, defecation, coughing, aggressive laughing, or hair brushing. In the pediatric world, we will often encounter situational syncope in patients who are having their hair brushed. You will encounter patients who are standing, having their hair brushed, braided, or fixed, typically in a small confined space such as a bathroom, often with an elevated ambient temperature. The combination results in hypotension, dizziness, and fainting. In contrast to simple dysautonomia, complex dysautonomia involves very similar dizziness or fainting, but also, more importantly, involves multi-organ system involvement. The two common types of complex dysautonomia include orthostatic intolerance and postural orthostatic tachycardia syndrome, or POTS. So the main difference between simple and complex dysautonomia is the involvement of other organ systems. So a variety of symptoms associated with the autonomic nervous system over and beyond simple dizziness and fainting. There are many signs and symptoms associated with dysautonomia. Symptoms can occur from head to toe and can involve essentially every organ system of the body. As you can see on this slide, there's a variety of symptoms that present. The larger fonted ones are the ones that are more common. Most common would be dizziness, lightheadedness, and fainting spells, followed by elevated heart rate or heart palpitations, chronic headaches, chronic fatigue, and chronic stomach problems. Here you can see a publication that breaks down the different symptoms based on which organ system is involved. Again, the most common presenting symptoms in the pediatric population are going to be dizziness, fainting, heart palpitations, headaches, fatigue, chronic abdominal pain, and nausea. Let's talk a little bit more about orthostatic intolerance. So both forms of complex dysautonomia, orthostatic intolerance and postural orthostatic tachycardia syndrome, will manifest as intolerance to the upright position. The key difference is the first physiologic event that occurs with the upright position. With classic orthostatic intolerance, the first physiologic event is a drop in blood pressure with the upright position, generally defined as a drop of the systolic blood pressure by 20 millimeters of mercury or more. In response to this orthostatic hypotension, the brain will release large amounts of adrenaline. One of the first physiologic actions of this adrenaline surge is to increase the heart rate, which is a compensatory mechanism to try and maintain cerebral perfusion. The ongoing chronic high adrenaline state is what leads to multi-organ system involvement. In contrast, the first physiologic event with postural orthostatic tachycardia syndrome is an increase in heart rate with little to no decrease in blood pressure. There are published pediatric diagnostic criteria for postural orthostatic tachycardia syndrome, which are listed on this slide, as well as summarized on the next slide. To be diagnosed with postural orthostatic tachycardia syndrome, symptoms of orthostatic intolerance must be present for greater than or equal to 3 months. By definition, there's an increase in the heart rate, 40 beats per minute or higher, in the first 10 minutes of the upright position. Importantly, there's absence of orthostatic hypotension, and there's absence of other conditions that may result in similar symptoms. Criteria have varied slightly throughout the years. This particular publication uses a heart rate increase of 30 beats per minute, but that's primarily in the adult world. So again, for pediatric patients, we're really looking for at least a 40 beat per minute increase in the heart rate with the upright position. Let's talk about basic diagnostic testing that can be done either by the referring provider or often is performed by the managing cardiologist or neurologist who specializes in dysautonomia care. First and foremost, as with all types of evaluations, we need to perform a comprehensive history and physical, looking for other conditions that may mimic orthostatic intolerance or postural orthostatic tachycardia syndrome. Referring providers may often perform bedside orthostatic measurements. This includes obtaining heart rate and blood pressure, in the supine and standing positions. Supine to begin with, followed by repeat vital signs at 2 minutes, 5 minutes, and 10 minutes in the upright position, taking special note to change in heart rate or change in blood pressure. Tilt table testing, which is a more formal form of orthostatic measurement, can be used. We will discuss tilt table testing on the next slide in a little bit more detail. It's often important to obtain some basic screening blood work. That includes a complete blood count, thyroid function, complete metabolic panel, vitamin D level, and ferritin level. We're looking for secondary findings that may either cause the dysautonomia picture or further exacerbate dysautonomia symptoms. And it should be no surprise that there is no universal biomarker that can be used to diagnose dysautonomia. Let's talk briefly about tilt table testing. A tilt table test is a formal orthostatic test that is performed typically in a hospital setting. This involves a patient lying supine on a bed, hooked up to electrodes, including an electrocardiogram, pulse oximeter, and heart rate monitor, as well as a blood pressure cuff. The patient is slowly moved to the upright position based on protocol, with an increase in the angle of the bed over the course of a prolonged period of time. Tilt table testing is rarely used in our practice as it does not change our treatment approach for most patients. Tilt table testing, however, is commonly used in more comprehensive dysautonomia clinics or centers, such as the Mayo Clinic Center for Autonomic Dysfunction or the Vanderbilt Dysautonomia Center. Most of these centers are academic and have ongoing research projects involving tilt table testing. Therefore, it is much more important in those centers. So what about the pathophysiology of postural orthostatic tachycardia syndrome? Well, it's really yet to be defined. It involves the convergence of multiple pathophysiological processes. There are no standard definitions other than the diagnostic criteria. There are a variety of subtypes of postural orthostatic tachycardia syndrome. Generally speaking, these are less clinically helpful as standard treatment is the same regardless of the subtype of postural orthostatic tachycardia syndrome or orthostatic intolerance. There are some nuanced differences that may result in some slight changes in management, but generally speaking, the same broad approach is instituted for all patients, regardless of their subtype of postural orthostatic tachycardia syndrome. To determine this subtype, you often need very intense dysautonomia testing, including tilt table testing, autonomic function testing, and sweat testing. Again, these are commonly done at comprehensive dysautonomia clinics, but are not things that we routinely do through our practice. Now let's move into common presentations in pediatrics. The most common presentation is going to fall into the idiopathic category. We also see a significant number of patients who present following a significant growth spurt or in and around menarche. This is suggestive of a sex hormone role in the dysfunction or dysregulation of the autonomic nervous system. The most common presentation in pediatric dysautonomia is a middle school to early high school female patient. As we know, during this time, there are significant hormonal surges that are occurring, and often the beginning of menstrual cycles. It is theorized that these sex hormone surges and changes are what is responsible for disrupting the autonomic nervous system. This theory is supported by the fact that once these patients reach more maturity and are more adult-like, especially in regards to sex hormones, typically towards the end of high school or early adulthood, their symptoms frequently resolve or become significantly less debilitating. There are classic post-infection presentations. For decades, we have seen patients who were diagnosed with mononucleosis develop dysautonomia following the infection. More recently, we've seen patients who present with autonomic dysfunction following the COVID infection. There will be patients who will also present with dysautonomia following a concussion. This post-concussive dysautonomia lacks the typical female predominance seen in typical POTS and orthostatic intolerance. Additionally, a high percentage of these patients will have complete resolution of their symptoms as their post-concussive symptoms resolve. Dysautonomia can also present following significant physical or psychological trauma. This can involve a major surgery, motor vehicle collisions, death of a loved one, divorce, and a variety of traumas, including sexual trauma. And lastly, there are some cases of post-immunization dysautonomia. This will be discussed in further detail in an upcoming slide. Briefly, let's discuss long COVID. Long COVID is essentially dysautonomia or autonomic dysfunction that appears to be related to a recent COVID-19 infection. These are dysautonomia symptoms that frequently persist on long beyond the acute infection. These patients often have predisposing autonomic dysfunction, meaning they had some degree of dizziness, lightheadedness, or fainting prior to the COVID-19 infection. These symptoms often worsen or are exacerbated by the infection. The pathophysiology remains unclear, but it's theorized that it's either an inflammatory response or an autoimmune response that further disrupts the autonomic nervous system. One study found that up to 50% of POTS patients reported a viral infection prior to the onset of symptoms. As mentioned before, we know that post-viral POTS has been an entity for several decades. There's controversy surrounding post-immunization dysautonomia. It is important for us to discuss two common vaccines with controversial associations to dysautonomia. The human papillomavirus, or HPV vaccine, is commonly administered to pediatric patients. There's a controversial association between vaccination for HPV and the autonomic dysfunction. Specifically, HPV vaccination has been associated with triggering many of the aforementioned diagnoses, including orthostatic intolerance, POTS, and chronic fatigue syndrome. And it is thought to be related to autoimmunity and autoantibodies in these patients. Currently, no conclusive evidence suggests the development of POTS in HPV vaccine recipients. And the possibility of developing POTS is not a contraindication to receiving the HPV vaccine. It should also be noted that the HPV vaccine is administered at the same age that most patients first develop autonomic dysfunction, late adolescence to early teenage years. Similarly, another publication reported odds of a new POTS diagnosis after COVID-19 vaccination in a cohort of almost 300,000 patients within 90 days of vaccination. POTS-associated diagnoses were 1.52-fold more likely after than before COVID-19 vaccination, although significantly less likely than in individuals infected with severe acute respiratory coronavirus 2, SARS-CoV-2. In addition to new diagnoses of POTS, they also identified increased odds of mast cell activation syndrome, but lower odds of Ehlers-Danlos syndrome after vaccination. This author proposed that patients may have systemic immunological responses to SARS-CoV-2 spike protein, although to a lesser degree than actual viral exposure. Next, we're going to transition to another important part of the talk, which is treatment of pediatric dysautonomia. When it comes to treatment, the main goal is symptom reduction and improved quality of life. This is a long-term or chronic condition with no known cure. I often will inform patients that there does not exist a provider or management plan that will effectively reduce all symptoms in a patient. Therefore, we will focus on improved quality of life, symptom reduction, decreased severity of symptoms, etc. Standard treatment starts with non-pharmacological interventions. When those are unsuccessful in improving quality of life, we move on to medication management. Throughout treatment, adjunct therapies, including physical therapy, exercise programs, mental health management, are employed. A multidisciplinary approach is needed for pediatric dysautonomia. This typically involves multiple subspecialties, managing the individual organ systems with a pediatrician or dysautonomia specialist, maintaining supervision and essentially being the quarterback of the dysautonomia care. We're going to review each of these non-pharmacological therapies in greater detail. Most of the non-pharmacological interventions are aimed at increasing blood pressure and reducing heart rate. Non-pharmacological therapies include aggressive fluid consumption, increased salt consumption, counter pressure maneuvers, use of compression garments, regular exercise regimen, dietary changes and supplements, sleep hygiene, and sometimes intravenous fluids. When it comes to fluid consumption, recommendations generally include increasing fluids to upwards of 3 liters or 100 ounces or more each day. This should be achieved primarily with water, but can also involve electrolyte drinks or sports drinks. We often will advise patients to minimize caffeinated fluids due to the diuretic effects of caffeine. Increased fluid consumption is the cornerstone therapy. Without achieving aggressive hydration and fluid consumption, most of the other treatment modalities will be unsuccessful. We aim for aggressive salt consumption. We aim for a total salt consumption on a daily basis of between 8 to 10 grams per day. This can be achieved by a combination of saltier foods, saltier snacks, use of electrolyte drinks, use of salt pills, and use of salt supplements. Generally speaking, pediatric patients are healthy with very healthy kidney function. This is the one area of cardiology where one may recommend or should recommend aggressive salt consumption. Salt is your friend in this scenario. With healthy kidneys, patients will excrete any excess salt that is not being utilized. It often takes some reassurance to families, especially their adult parents, that this amount of salt is perfectly safe given the scenario that we are treating. Salt pills come in a variety of forms. Sodium chloride tablets are easy to obtain, are very large, often 500 to 1,000 milligrams of sodium chloride per tablet. These can sometimes not be tolerated very well for patients. It can induce abdominal pain and nausea. That's where buffered salt pills come into play. Buffered salt pills typically also include potassium. This buffers them and makes them much easier on the stomach and are better tolerated. There are a variety of salt supplements on the market. Here you can see a couple of the more commonly used salt supplements. Counter-pressure maneuvers involve repeatedly squeezing large muscle groups, which increases circulation and brain perfusion. This should be instituted routinely before any change of position or during acute symptoms. What does this mean in reality? Patients should learn to squeeze their calf muscles, squeeze their thigh muscles, clench their buttock muscles before ever sitting up or standing up, getting out of a chair, getting out of bed. By squeezing these large muscle groups, blood that has been pooling in the lower extremities will be forced back to the heart for improved circulation and blood pressure. Additionally, simply squeezing muscles will raise the blood pressure. For example, if you're checking a standard blood pressure in the arm and a patient squeezes their bicep or their fist, the blood pressure will go up 5 to 10 points or more with that squeezing of the arm muscles. This should become second nature, should become a habit. Patients often need to do it for a few seconds or longer in order to increase the perfusion to the brain. Compression garments can be very beneficial. Compression garments such as knee-high socks or thigh-high, waist-high tights decrease lower extremity venous pooling and increase venous return. Essentially, they augment the squeezing of the muscles to improve venous return to the heart, which increases blood pressure and brain perfusion. Generally speaking, the higher the better. At least thigh high is needed for maximum benefit. One should look for compression garments that are 20 to 30 millimeters of mercury of compression. Unfortunately, compliance is poor due to comfort and lack of style points. Compression garments are tight and hot, which makes it difficult to wear in our environment. Abdominal binders are sometimes used and have been shown to show some benefit in helping with pelvic or abdominal venous insufficiency. I typically recommend compression garments for all patients, but find them extremely helpful for patients who have activities that require prolonged upright position. This could include patients who participate in the marching band, who work as a waiter or waitress at a restaurant, or maybe work at the cash register at a grocery store. These activities that require prolonged standing can benefit from compression garments. Exercise is extremely important in patients with dysautonomia. Exercise is used to avoid deconditioning. With dysautonomia, patients often become less active, which means loss of muscle tone. Muscle tone is important for helping with venous return to the heart. Exercise regimens should start with maneuvers that do not require upright posture, which could exacerbate orthostatic symptoms. These types of exercises could include rowing, swimming, or recumbent bicycles. Strength training improves physical deconditioning and improves stroke volumes and leads to improved quality of life in these patients. Physical maneuvers such as leg crossing, muscle pumping, and squatting may also improve acute symptom onset. There is a specialized protocol referred to as the Levine protocol, which is a 3-month exercise program that has shown efficacy in lowering heart rates and improving cardiac output in patients with POTS. Physical therapy can also be especially helpful for patients who have postural orthostatic tachycardia syndrome or orthostatic intolerance. It is extremely helpful in patients who have joint hypermobility or maybe have the comorbidity of Ehlers-Danlos syndrome. Exercise regimens, again, in brief review, should include low impact, strength building activities that do not induce dizziness or lightheadedness. So typically begins with recumbent type activities. Dietary changes are often needed as part of the holistic approach to treatment of pediatric dysautonomia. Universally, we recommend our patients consume a vitamin D supplement every day of at least 2,000 international units daily. For female patients, we also advise that they add a multivitamin with iron to their regimen. It has been shown that supplementation with iron and vitamin D improves chronic dizziness, even in the absence of iron deficiency anemia or vitamin D deficiency. We want to optimize these levels to help chip away at chronic dizziness. Patients often have significant abdominal symptoms, including chronic nausea and chronic abdominal pain. The basic dietary approach, at least to start with, involves small proportioned meals. Small, more frequent meals throughout the day may decrease postprandial gut venous pooling and improve GI symptoms. Additionally, high fiber diets can improve GI symptoms often encountered, such as constipation. For some patients, gluten-free diets, in particular, have shown improvement in autonomic symptoms. Most notably, those with significant orthostatic symptoms, vasomotor symptoms, and gastrointestinal symptoms. This is not a universal recommendation, but something a patient may want to try if they have significant gastrointestinal symptoms associated with their dysautonomia. There is some controversy regarding the use of intravenous fluids. Some providers will recommend regular intravenous infusions, say on a weekly or bi-weekly basis. And within our practice, we typically recommend intravenous fluids only for acute decompensation and for patients who cannot tolerate oral hydration due to GI symptoms. So this may be an acute gastrointestinal illness. Maybe it's an acute viral infection, such as influenza or COVID, where oral intake decreases. The sudden increase in intravascular volume from the fluids can improve dysautonomia symptoms and move the patient back to baseline following the illness in a quicker manner. The main limitations with long-term use or frequent use of intravenous fluids include the inconvenience, getting insurance to cover the IV fluids, and probably most importantly, long-term IV access. We advise against the use of PICC lines or ports in these patients due to the risk of infection and thrombosis. So we always start with the non-pharmacological interventions. Those are cornerstone. Those are vitally important. When those interventions aren't reaching the quality of life that the patient would like to achieve, then we start thinking about medication management. We have medicines that address different physiologic responses within the body. We have medicines that target vascular tone, target rapid heart rate, target hypovolemia, target sympathetic activity, and can help manage menorrhagia, which exacerbates dysautonomia symptoms. In regards to vascular tone, the main medicine used is midodrine. Midodrine is an alpha-1 adrenergic agonist. It works by inducing peripheral vasoconstriction, improving venous return to the heart. This requires a 2 to 3 time daily dosing, but does carry minimal side effects. The most common side effects reported include scalp tingling or piloerection, commonly referred to as goosebumps. This medicine is safe, well tolerated, and requires no ongoing monitoring. We do recommend avoiding a late evening dose due to supine hypertension. In reality, this means taking the final dose between somewhere 5, 6, or 7 p.m. to avoid medication-induced hypertension and supine hypertension occurring at the same time. There are 2 different classes of medications that are often used to address heart palpitations. Patients with dysautonomia often report elevated heart rates. They report increased heart rate variability, exaggerated heart rate responses to typical activities, and more random benign heart palpitations. There's nothing dangerous about the heart palpitations. They're not experiencing arrhythmia. However, the elevated heart rate often results in feeling poor, inducing other symptoms, including inducing anxiety. Therefore, as with most medications, we're treating to improve the quality of life related to these symptoms. Beta blockers are often the first-line medication used to address rapid heart rate. They work in a variety of ways, including reducing the cardiac baroreceptor activation, lowering serum norepinephrine levels, and inhibiting sympathetic nerve activity. This results in lower heart rate and decreased response to the chronic adrenaline surge seen in patients with dysautonomia. Shorter-term acting medicines are often used, including propranolol. But long-term, single daily dose beta blockers, such as nadolol, can also be instituted. Second-line therapy for patients with heart palpitations or rapid heart rate includes the use of ivabradine. Ivabradine, also known as Corlinor, blocks the funny channel of the sinoatrial node, resulting in a lower heart rate without any effect on lowering the blood pressure. This is what makes ivabradine an amazing drug for the treatment of palpitations in patients with POTS and orthostatic intolerance. They get decreased heart rate without any effect on blood pressure. Ivabradine is dosed twice daily and is gaining increasing usage due to its efficacy. Additionally, it is now generic, so accessing ivabradine in an affordable manner is much easier than it was several years ago. To treat hypovolemia and to increase intravascular volume, we can use fludrocortisone or Florinef. This is a glucocorticoid that promotes salt and water retention in the kidneys. This can be dosed once or twice daily. Unfortunately, given the fact that it is a glucocorticoid, there often are side effects associated with the systemic nature of the medication. Most commonly reported side effect would be headaches. Patients will also often report weight gain, acne, or mood changes due to the systemic side effects. Some providers advocate monitoring for hypokalemia when using fludrocortisone. Medicines that help manage the sympathetic activity include clonidine. This is an alpha-2 adrenergic receptor agonist. Clonidine decreases central sympathetic activity, thus reducing autonomic instability. This is often prescribed by either neurology or psychiatry, and commonly is used to also help treat or help with sleep disorders in these patients. It's very important to screen and evaluate for menorrhagia, which would increase risk for anemia. Anemia further exacerbates dysautonomia symptom by causing more dizziness. We recommend universal iron supplementation to avoid anemia. For patients with significant menorrhagia, referral to gynecology may be needed. We typically will recommend low-dose estrogen or progestin-only hormonal regulation in patients with significant menorrhagia to help avoid anemia. There are a variety of commonly associated conditions that we see in patients with POTS and orthostatic intolerance. These may be referred to as coexisting or comorbidities. You can see a variety of things listed here that we often encounter. More common are chronic migraines, chronic fatigue syndrome, functional GI disorders, and joint hypermobility, including Ehlers-Danlos syndrome. One commonly associated condition is called mast cell activation syndrome, or MCAS. This is early or excessive histamine release in response to exercise or orthostatic stress. Often patients will describe flushing, urticaria, pruritus, nasal congestion, and changes in bowels, including diarrhea, with the upright position. The most common diagnosis and presentation would be lower extremity or distal extremity flushing and urticaria, as well as pruritus with prolonged standing. This is a very difficult diagnosis to definitively make. It also often involves the help of an allergist, and baseline standard treatment for this condition starts with antihistamine therapy. There are many patients with dysautonomia who will also be diagnosed with hypermobility type Ehlers-Danlos syndrome. This includes symptoms of generalized joint hypermobility, easy bruising, and stretchy skin. It should be noted that hypermobility type Ehlers-Danlos syndrome is not genetic, and therefore there is no genetic testing that can be done, as with other types of Ehlers-Danlos syndrome. This is a clinical diagnosis using the Beighton score. Suspicion for Ehlers-Danlos syndrome is raised in a patient with hypermobility, significant joint pain, and fatigue. Treatment involves aggressive physical therapy to increase muscle tone and improve joint stability. Chronic fatigue syndrome is often encountered in patients with dysautonomia. This includes debilitating fatigue, mental and physical exhaustion and malaise, chronic pain, and cognitive impairment. Approach requires a multidisciplinary management team. Most importantly, in the treatment of chronic fatigue syndrome is mental health care. To achieve success in the treatment of patients with dysautonomia, it often requires management from a variety of subspecialties, given the variety of symptoms and comorbidities that can occur. The multidisciplinary approach often includes cardiology, neurology, and gastroenterology. Other subspecialties such as allergy immunology or pain medicine may be needed based on presentation. Mental health care, from basic counseling to psychiatric care, should be universally instituted. These patients will often have significant mental health symptoms related to the chronic nature and debilitating nature of the condition. So getting appropriate mental health care is paramount. As we close up our discussion, let's discuss prognosis. The good news regarding pediatric dysautonomia is most patients have resolution of their symptoms, or at least a significant decrease in their symptoms by early adulthood. Adolescence, when half of patients with POTS are diagnosed, as an important time in which many changes occur in the body, demonstrating significant contrast to adults. During puberty, hormonal changes cause somatic growth, brain maturation, psychological maturation, and gonadal growth and maturation, although it is unclear how these affect the onset, pathophysiology, and outcomes. Studies have shown a significant reduction or improvement in symptoms over time in patients with pediatric dysautonomia. In 2019, a study showed that 48% of pediatric patients were symptom-free 1 year following diagnosis, and 85% were symptom-free at 6 years. Why did these patients improve? Well, anecdotally, we have noted patient symptoms improving when attending college. This may be because of increased time between classes, with more recovery time, increased neurological maturation, allowing for improved ability to recognize and avoid triggers, and often just simply being away from overbearing parents, forcing the patient to accept responsibility of their own disease management. It could also be the aforementioned improvement in symptoms with time due to hormonal maturation. A unique factor that pediatric patients have is parental involvement. Parents can be strong advocates, getting these children to a knowledgeable and caring provider, especially when symptoms are ignored or misinterpreted by other providers. They network with other parents to optimize their child's care and remind or push their children in routine care management. However, parents can generate hindrance to their child's progress. They may expect rapid return of their high-achieving child to school or sports. They may have difficulties allowing their child to mature or to fail. Parents may have their own untreated medical or psychological issues influencing their child's treatment, sometimes feeling compelled to maintain caregiver status as a secondary gain. They may also not recognize comorbid psychological issues in their children. Pediatric dysautonomia often has a significant impact on the patient's educational process. Their symptoms often result in frequent absences from school. These patients often require some sort of modified educational approach. This could include hospital homebound, online education, some type of hybrid school day, and classroom accommodations. Most of these patients will meet requirements for a 504 plan. So I appreciate your time today as we've talked through pediatric dysautonomia. Pediatric dysautonomia involves a variety of symptoms across the late adolescent, teenage, and adult time frame. It's important for the primary care team to have early recognition to avoid prolongation of symptoms and frustration with the medical system. It's also extremely important that we validate the symptoms of the patients. The symptoms they are experiencing are real and should be validated. A thorough history and physical to rule out other conditions with similar presentations should be completed prior to referral to a specialty clinic. Workup should often include some baseline basic work laboratory evaluation. And then referring out to a dysautonomia specialist, such as our complex syncope clinic, is a useful resource that you have available. Thank you again for your time today. If you have any questions, I'm more than happy to take your calls and answer your questions. It would be very beneficial if you would take a moment to review this presentation. The QR code is found here for your reference. This will provide valuable feedback for us as we evaluate this presentation and enhance future educational opportunities.